Welcome to the deep dive. Today we're plunging into something really critical in healthcare, medication safety. Or maybe, more accurately, medication harm.
That's right, because adverse drug events, ADEs, are actually the most frequent source of mishaps in healthcare. It's a constant risk patients face.
And what's kind of shocking is how poorly the traditional ways of catching these events seem to work.
Utterly ineffective, really. Our sources suggest they miss, well, up to 50 times more events than some newer approaches. 50 times.
Wow. Okay, so our mission today. Let's get into how this seemingly simple trigger tool is changing the game for patient safety detection.
Let's do it.
Okay, so let's unpack this a bit. Lots of folks, including hospitals, focus on medication errors. Makes sense on the surface.
Uh-huh.
But the sources we looked at draw this really sharp line between errors and adverse drug events. Why does that distinction matter so much?
It's a fundamental shift, really. An ADE, according to the World Health Organization definition, is basically harm to the patient.
What?
Yes. A response to a drug which is noxious and unintended. It's focused purely on the outcome. Did the patient get hurt?
So, wait, an ADE could happen even if the medication was given, correctly, following all the steps.
Exactly. That's the crucial part. Errors are about the process. Did someone make a mistake giving the drug? And ADE is about the result. Was there harm? They're related, but not the same thing.
Okay, outcome focused. But why is that shift so important practically? If hospitals are already looking for errors, why does zeroing in on harm make such a difference?
Well, think bigger picture. It lets hospitals channel their resources, their time, their focus on stopping things that actually hurt patients.
Right.
If you're just chasing process errors, you might spend a lot of effort on things that thankfully didn't cause any harm.
Okay, I see.
Meanwhile, serious harm might be slipping by unnoticed. By focusing on ADEs, on the harm itself, you prioritize interventions that truly make patients safer.
And the data backs this up.
It does. The sources show most ADEs, about 80%, cause temporary harm. That's category E. But, and this is sobering, 1.8% actually contributed to a patient's death. Category I.
Wow.
So focusing on harm means you're targeting interventions that could prevent everything from temporary issues right up to those tragic outcomes.
Okay, that makes a lot of sense. Focusing on harm is clearly powerful, but how do you actually find these harm events, especially if old methods were missing so many? Tell us about this trigger tool. You called it low tech.
Yeah, it's surprisingly straightforward. It's a practical method, really refined by the IHI, that's the Institute for Healthcare Improvement and Premier.
Okay.
Instead of just waiting for someone to fill out a report, which often doesn't happen, trained teams actively scan patient charts.
Actively looking. For what?
For specific triggers. These are like little red flags, signals that an ADE might have occurred.
Like what kind of signals?
Oh, things like an order for an antidote medication,
Yeah.
like naloxone, which reverses opioid effects if that's ordered.
Yeah.
It suggests maybe oversedation happened.
Ah, okay. Makes sense.
Or, say, looking at lab results. A sudden, really sharp drop in blood sugar, maybe below 50 mg/dL. That's a trigger.
Got it.
Even something noted as an abrupt medication stop. The tool actually coded that one as T22. That specific trigger turned out to have the highest yield, finding ADEs in about 35% of the cases it flagged.
35% just from stopping a med abruptly.
Yeah, it's a strong indicator something went wrong. And the review process itself is designed to be quick.
How quick?
They aim for about 20 minutes per chart, so it's manageable for busy staff.
20 minutes. That's efficient. So what happened when they tested this? What was the actual impact?
The results were, well, dramatic. They tested it across 86 hospitals, looked at over 2,800 patient charts. And the trigger tool found ADEs about 50 times more effectively than the traditional reporting systems those same hospitals were using.
50 times. That's staggering.
It really is. And get this, only 1.8% of the ADEs that the trigger tool identified had also been picked up by the hospital's existing older reporting systems.
Wait, only about 2%. So 98% were just being missed entirely before.
Essentially, yes. Missed. Invisible. It highlights just how much harm was likely occurring under the radar.
Why were the old systems so bad at this?
A lot of it comes down to relying on people to voluntarily report incidents. And, that's just notoriously inconsistent for all sorts of reasons. Plus, the trigger tool approach is easy to implement.
Easy.
Yeah, the training for the teams doing the reviews takes just about 30 to 60 minutes.
Half an hour to an hour. That's it.
That's it. Which shows it's something most hospitals could realistically adopt and get reliable data from.
So, wrapping this up for today, we've really seen how shifting focus from just errors to actual harm and using this clever trigger tool is fundamentally changing medication safety. It's about finding the harm that was previously hidden.
Exactly. And it really makes you wonder, doesn't it, as this more effective, efficient way of finding problems spreads, what kind of impact could that have globally? How much patient harm could actually be prevented worldwide?
That's a huge question. What really stands out to you from all this? Maybe the sheer scale of what was being missed, or maybe just how simple, relatively speaking, the solution turned out to be. Definitely something to think about until our next deep dive.